Welcome to the learning module over nucleotide catabolism. This is Dr. Doug Tefke for Cellular and Molecular Medicine. After viewing this learning module, students should be able to describe the production of uric acid from purines, explain the importance of xanthine oxidase in degradation of purines, describe how purine degradation contributes to hyperuricemia and gout, explain how mutations in PRPP synthetase and HGPRT can cause hyperuricemia and gout, understand how radiation and chemotherapy can cause hyperuricemia, identify the clinical symptoms of gout and describe how gout is diagnosed, describe why allopurinol is used to treat hyperuricemia and gout, explain how defects in purine degradation cause immunodeficiencies and give examples, describe the symptoms and underlying cause of ADA skids, and describe the clinical significance of pyrimidine degradation. Degradations of purines lead to the production of uric acid. Nucleotides are converted into nucleosides by the action of 5' nucleotidase. Adenosine is deaminated by adenosine deaminase, or ADA, to inosine, while AMP is deaminated by AMP deaminase to IMP. Nucleosides are then cleaved to free bases by purine nucleoside phosphorylase, or PNP. Inosine is converted to hypoxanthine plus ribose 1-phosphate. Xanthosine is converted to xanthine plus ribose 1-phosphate. Guanosine is converted to guanine plus ribose 1-phosphate. The ribose 1-phosphate can then be isomerased to ribose 5-phosphate for reutilization in the cell. Guanine is deaminated by guanase, a guanine deaminase, to xanthine. Xanthine oxidase oxidizes hypoxanthine to xanthine and xanthine to uric acid. Uric acid is the end product of purine catabolism in humans. Essentially, the pathway for the synthesis of adenine and guanine bases from IMP is reversed so that they are converted back into hypoxanthine and xanthine. This is where understanding and knowing the structural differences between the bases helps remember or to deduce the steps in the degradation pathway. Knowing that adenosine and guanine are animated derivatives of inosine, hypoxanthine, and xanthine allows you to remember that they are deaminated during their catabolism back to inosine and then further converted to uric acid by the activity of xanthine oxidase. Genetic defects in adenosine deaminase or in purine nucleoside phosphorylase result in immunodeficiencies. Xanthine oxidase can oxidize two different sites on the purine ring. Uric acid is the end product of purine metabolism in humans. Uric acid is also 2,6,8-trioxypurine. Uric acid has a pK of 5.4 and is not very soluble in aqueous media. In the body, it is ionized to urate, which is slightly more soluble than uric acid. Urate and uric acid are both excreted in the urine. The rate of uric acid excretion by the normal adult is about 600 milligrams every 24 hours, arising in part from ingested purines and in part from the turnover of the purine nucleotides and nucleic acids. The normal concentration of uric acid in the serum of adults is in the range of 3 to 7 milligrams per deciliter. A consequence of hyperuricemia can be gout, which is a recurrent acute arthritis of the peripheral joints caused by the accumulation of monosodium urate crystals. It often presents as sharp pain and swelling confined to one joint. The joint of the big toe is a commonly afflicted area. Although hyperuricemia and acute arthritic pain in a joint are symptoms of gout, gout diagnosis is made upon identification of negatively birefringent monosodium urate crystals in aspirates of synovial fluid. Excess uric acid can also form deposits in the kidney tubules, resulting in kidney stones. The advanced gout stage is often referred to as chronic tophaceous gout to indicate the presence of this clinical manifestation, which will remain unresolved in the absence of urate-lowering therapy. Tophi are characterized by urate deposits in connective tissue that produce irregular nodules and joint destruction. In addition, the skin overlying the tophi may become ulcerated and exude a white chalky material. Shown here are some common sites of tophi, including dermal tophi on the finger, periarticular tophi on the hands, and tophi on the helix of the ear. The patient with the polyarticular involvement of his hands had been misdiagnosed and treated for rheumatoid arthritis for over 8 years. There are several causes for hyperuricemia and gout. There can be excess synthesis of purine nucleotides, which are then degraded. Sometimes there are activating mutations in PRPP synthetase, which can elevate phosphoribosyl pyrophosphate levels, which can stimulate de novo biosynthesis. Remember, PRPP stimulates glutamine phosphoribosyl aminotransferase, the committed and control step in purine biosynthesis. There can be inactivating mutations in salvage enzyme hypoxanthine guanine phosphoribosyl transferase, the enzyme that is defective in Leishman syndrome. Reduced HGPRT activity reduces the usage of PRPP for salvage. The accumulation of PRPP then stimulates de novo biosynthesis of purines via activation of glutamine phosphoribosyl pyrophosphate aminotransferase activity. Von Gerke's disease is a glycogen storage disorder resulting from a defect in the glucose 6-phosphatase gene. Oxidation of glucose 6-phosphate via the pentose phosphate pathway leads to increased production of ribose 5-phosphate, which stimulates purine biosynthesis. The excess purine nucleotides then are degraded to uric acid. Chemotherapy and radiation therapy for certain cancers can result in tumor lysis syndrome. When these tumor cells die, the nucleic acid contents have to be degraded. This excess degradation of purines results in hyperuricemia. Diets rich in foods with high purine content can also contribute to hyperuricemia. Liver, for example, is very high in nucleic acids, as is, unfortunately, beer. However, the most common cause of hyperuricemia and gout are defects in excretion. Acute gout attacks are often treated with colchicine and indomethacin to reduce the inflammation. Colchicine disrupts microtubules necessary for neutrophil function, and indomethacin inhibits cyclooxygenases. Long-term treatment utilizes allopurinol to reduce production of uric acid. Allopurinol is oxidized by xanthine oxine to alloxanthine, or oxypurinol, which is an irreversible suicide inhibitor of xanthine oxidase. Inhibition of xanthine oxidase causes uric acid levels to drop and levels of hypoxanthine and xanthine to rise. Essentially, this spreads the amount of purine degradation among 3 products instead of 1. Accumulating hypoxanthine can also be salvaged by hypoxanthine guanine phosphoribosyl transferase, which helps reduce PRPP concentrations in the cell, helping to slow the de novo synthesis of purines. Allopurinol inhibits the conversion of hypoxanthine to xanthine and xanthine to uric acid, therefore spreading out the degradation of purines into 3 products instead of concentrating it in 1. A new xanthine oxidase inhibitor, febuxostat, is also now in use, while probenecid increases the renal excretion of uric acid. Defects in purine degradation pathway can result in immunodeficiencies. Adenosine deaminase deficiency causes severe combined immunodeficiency disease, also known as ADA SCIDS. It's an autosomal recessive disorder in which the individuals lack both T and B cells, and therefore they lack a functional immune system and must live in a sterile environment. Treatment options are few. Individuals can either have a bone marrow transplant, which requires a matching donor, or they can undergo gene replacement therapy. ADA SCIDS was the first genetic disorder successfully treated with gene replacement therapy. A deficiency in purine nucleoside phosphorylase causes a less severe form of immunodeficiency, affecting only the T cells. ADA deficiency accounts for approximately 15% of all cases of SCIDS. It may present at infancy, in childhood, or early adolescence. The age of onset and severity is related to some 29 known genotypes associated with the disorder. PNP deficiency is an autosomal recessive disorder that is extremely rare, with only approximately 30 or so cases having ever been documented in the United States. Under conditions of adenosine deaminase deficiency, deoxyadenosine will accumulate and be converted to deoxy-ATP by kinases. Deoxy-ATP inhibits ribonucleotide reductase. Therefore, deoxynucleotide triphosphates needed for stem cell division are not available. This produces a lymphocytopenia. So why are immune cells specifically affected by adenosine deaminase deficiency? One hypothesis is that the other cells in the body secrete deoxyadenosine that they cannot use, and it accumulates in the circulation. As lymphocytes are present in the circulation, they tend to accumulate deoxyadenosine more so than cells that are not constantly in the blood. Unlike purine degradation, degradation of pyrimidine bases leads to completely water-soluble compounds. Cytosine and uracil degrade to beta-alanine, ammonia, and carbon dioxide. Thymine degrades to beta-amino isobutyric acid, ammonia, and CO2. Unlike degradation of purine nucleotides, there are no significant metabolic disorders associated with degradation of pyrimidines. Here are a few questions to test your knowledge of purine catabolism pathways.